Hello, good morning, everyone. Thank you so much for joining us today. Today, we are gonna discuss very important topics. Today, we're gonna discuss management summaries in SCA. So, management summaries are very, very important topics that we normally go through, and it's a very important um, kind of a step actually whenever you are preparing for your SCAs. This is a very crucial step. Why it is very crucial? It is because the fact that you've already done your preparation, but the preparation might not be very organized in your mind, and you'd like a little bit of organization and specifically the management plans. Management plans are very, very, very important. Management part in your SCA, you will go through 4.5 marks in every single case. And our main aim is that we would like you to ace the SCA with flying colors. Actually, would like you to pass every single domain with a clear pass. Now, management is one of the trickiest parts in the SCA, and that's why we managed to summarize all of the important information, all of the important details that you should be aware about as a GP in general and as a GP trainee specifically as well. So let's start today. Today is going to be a long day, tomorrow as well. So please bear with me. Make sure that you bring your coffee, and we are going to start now. So first chapter, first branch for today is going to be cardiovascular. So let's start with our topic in cardiovascular. Hypertension. Hypertension is quite a very, 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 very common medical condition we normally see in our day-to-day life, and it is very, very, very crucial condition. And we always need to know about hypertension as GPs. We need to know how to deal with it in a very, very good way. We are always expected to know how to deal with hypertension. So what is hypertension? Again, we've mentioned before, if you haven't attended our sessions in the past, how to explain any medical condition in a very easy way. Actually, it is a very organized way, makes your time very, very concise, because if many doctors actually tend to struggle to find words, tend to struggle to explain a diagnosis, and actually takes them a long time in the management part when they are going to explain diagnosis. So be structured. This is very important. How to be structured? Again, start by thinking, is it a long-term condition? Is it a short-term condition? Hypertension, is it a long-term condition? Is it a short-term condition?
Long-term.
Long-term, perfect. Is it a common, uncommon, very common, or is it fairly common condition?
Common condition.
Very common, very, very common, very common. I bet any of you who actually seeing patients on day-to-day basis, you see hypertension on a daily basis. You see patients with high blood pressure, at least high blood pressure in their background and on a daily basis. So this is very important. Okay, what normally happens in hypertension? So hypertension is increased pressure in the blood vessels. So this is how to explain hypertension. We are not finished yet. We are not done yet. The following part is actually we need to say whether this condition is a treatable condition, is it untreatable condition, or can it be brought under control with specific measures and medication? What do you think?
It is a manageable condition.
Perfect. Thank you so much.
A control, yeah.
Absolutely. And last but not least, specifically with longer term conditions, specifically with urgent conditions, we need to mention what happens if this condition is left untreated. What happens if hypertension left untreated? What can happen is it can affect our eyes, it can affect our kidneys, can affect our heart. So all of these can be complications of hypertension. So these are very, very important things. And this is a very important way of explaining any medical condition on earth, actually. Now, hypertension. What is management of hypertension? So Again, patient coming to you in the clinic reading is not always diagnostic. Clinic reading actually is something actually that gives you an indication or gives you information that this patient is having suspected hypertension. But the best way of doing it is by doing home blood pressure monitoring, ambulatory blood pressure monitoring. Home blood pressure monitoring, check your blood pressure in the morning and in the evening for 7 days time. And by that, we will calculate the average of your blood pressure, and actually we can by then diagnose hypertension. But what else? Blood's very important. Do full blood count, T&Es, liver functions, lipids, thyroid gland functions. As we've mentioned, actually, why we're doing this before, and we are doing this actually is because of complications of hypertension. Hypertension can lead to stroke. Hypertension can lead to, TIAs. Hypertension can lead to brain damage, can lead to kidney damage. So all of these are very important to be done. Even though if you are suspecting hypertension, you can still do that while it's awaiting for home blood pressure monitoring. However, leave that until if the patient's high blood pressure is sky high, and by that I mean around 180 over 120, for example, and the patient doesn't have end organ damage. By that I mean the patient doesn't have, for example, loss of vision. The patient doesn't have any blood in urine or any protein in urine. Then at that point you can go ahead and do blood tests straight away. Don't wait for anything. Don't wait for home blood pressure monitoring. However, if the patient's blood pressure, clinic blood pressure reading is average on the higher side, then you can do the home blood pressure monitoring, and then you can accordingly do blood tests, ECG, urine dip. Why do we do a urine dip?
Check for hematuria and protein.
Perfect. To do an ACR, very important. ACR to check for kidney functioning. This is very important. ECG for heart tracing. So this is a triad. This is a triad for a patient who is coming to you today, who is having hypertension, diagnosed hypertension. You need to do blood tests, urine dip for ACR and ECG. Also very important to get their eyes checked on yearly basis. Dr. Nohir, yes, please.
Yeah, so if the patient having blood pressure at clinic 180 over 120, this means we need to meet on the same day. So we give them the medication same day. We don't need to wait for 7 days, right?
Yes. So another thing, yes, we can start the patients straight away on antihypertensive medication in that occasion. However, as we've mentioned, again, if the patient is having end organ damage, and we've mentioned what end organ damage is, such as loss of vision, for example, patient needs or reduced vision, patient needs to be seen during the same day in hospital. Okay, so high blood pressure, malignant hypertension, 180 or 120, for example, without end organ damage, patient can be monitored very closely in primary care. And when we say very closely, patient needs to be started on medication, patient needs to be reviewed again in 1 week's time. Patient at the same time needs to do home blood pressure monitoring while it's being on medication, and until they come and see you after 1 week's time as well. Right, what else we need to do is antihypertensive medications. We're going to have a chat about that, and also consider statin treatment. Very important when you're seeing a patient hypertension, you need to calculate the Q-risk score, and that's why we're doing a lipid profile. It gives us a very important information about this patient's Q-risk score. Now, Q-risk score is a medical calculator that actually assesses the probability of having strokes, many strokes in the next 10 years. This is how to explain a Q-risk score. So very important to keep that in your mind. Now, dietary advice. Now, lifestyle advice. And it's very important because many patients tend to add salt to their diet. And they need to cut that down. If a patient smokes, patient drinks alcohol. If they do smoke, they need to stop smoking. If they do drink alcohol, they need to cut down. Of course, very important. Put in your mind that a patient, if they are overweight, if they are obese, they need to lose weight. Very important. We are moving into our next bit, which is hypertension general rules. So all of you are aware about that, but it's just a kind reminder. Patients who are 55 and above or Afro-Caribbean, it's always calcium channel blocker to start with. Patients who are below 55 or diabetics, patients need to be started on either ACE or ARBs. However, if they are Afro-Caribbean, normally we would like to start them on ARBs such as candesartan, such as losartan. Why? Anybody knows why? Because it has been proven that ARBs, candesartan, losartan work better when it comes to Afro-Caribbean patients compared to the ACE inhibitors. Okay, so again, if patients are below 55, general rule is actually ACE inhibitors. Patients who are diabetics, general rules, ACE inhibitors. However, if patients are Afro-Caribbean, then, and actually either below 55 or diabetes patients, then we should be starting them on ARBs such as candesartan or losartan. I hope this is clear. If an Afro-Caribbean person or patient is coming to you and he is 65, what would you start them on?
Calcium channel blocker?
Calcium channel blocker, yes. Perfect. Thank you so much. Perfect. Thank you so much. You are concentrating with me. Thank you so much. Now, patient with heart failure, of course, in addition to heart failure treatment, we should always think about starting thiazide diuretics as a first line in that part, in that case. So, thiazide diuretics, such as what?
Is it indapamide?
Yes, perfect. Thank you so much. Thank you so much. So normally we can start on indapamide because indapamide actually is very good. Actually, it's considered as a water tablet and takes any fluid overload away. Yes, Dr. Pedro.
What about furosemide? Is not.
Yeah. Furosemide, we can do that, but furosemide is mainly not an anti-hypertension medication. Furosemide is actually a water tablet.
So I mean for heart failure.
Yes, for heart failure. Yes, sorry, it's not a heart failure medication. So no, patients with heart failure alone without hypertension,
Okay.
then we can start them on furosemide.
Okay.
Patients with heart failure and hypertension, then the first choice of their treatment is actually thiazide, because thiazide is a very good anti-hypertensive medication plus a very good diuretic. Okay. I hope it's clear. I hope it is. Thank you. If a maximum dose is not tolerated, always check compliance. We need to make sure the patient is actually taking medication as it should be. The patient is not missing doses of their medication. If the maximum dose is not enough, move on into the next step. So don't add another medication until you have exhausted your current one. For example, patient 55 years old and above, patient on calcium channel blocker, patient is on amlodipine, for example, and patient is on 5 milligrams of amlodipine or whatever, low dose, moderate dose, and the patient still blood pressure is not under control, then think about, would I be able to increase the dose of this medication? Yeah, if yes, then increase the dose of the medication before shifting into the following one. So before adding another medication, you need to complete, you need to continue, you need to actually reach the maximum strength of the medication that the patient is on if hasn't been done. I hope this is clear. Now, you added a second medication, still not helping, patient is compliant, then third step is going to be adding a third medication. Now, if the third medication not helping at that point, you need to do what? Either one of two things. So the first thing is actually you need to recheck actually ambulatory blood pressure measurement. at that point, you can also seek specialist advice. So either doing ambulatory blood pressure monitoring or seek specialist advice before adding the fourth drug. Remember, when did we actually mention about ambulatory blood pressure monitoring early on? When did we come across that? We just came across that a few minutes. So at the beginning, whenever we are diagnosing and hypertension disease, hypertension condition, whenever we are diagnosing, we need to start by doing ABPM, ambulatory blood pressure monitoring or home blood pressure monitoring. However, if we are reaching the last step in primary care, which is adding a fourth drug, we still, as well at that point, need to do ambulatory blood pressure monitoring. Okay, so doing ambulatory blood pressure monitoring is in two cases, either at the start or at the end. Okay, now if you, for example, have added a second medication or third medication, exhausted your options, now what can be your options? If you added a third medication, patient is not still controlled, then you need to do blood tests. Why is it important? Because we need to check potassium. Because if potassium is high, what can be your options here?
Beta blocker or alpha blocker?
Yes, perfect. Thank you so much. Okay, beta blockers or alpha blockers. So beta blockers like what?
Bisoprolol.
Bisoprolol. Yeah, perfect. Alpha blocker like doxazosin. All right. Now, these medications are good, but can have side effects. These side effects can be actually dizziness, can be drowsiness, loss of consciousness in patients who are severely frail. So we need to warn the patient against these side effects. However, if potassium is normal or 4.5 and less, then we can consider spironolactone. So why spironolactone? We do that if potassium equals to or below 4.5. Why do we do that?
It's a potassium sparing diuretic.
Okay, perfect. So that's going to increase potassium in the blood, which can be quite dangerous. Now, all of these medications can cause erectile dysfunction. Many patients can actually tend to suffer from erectile dysfunction when they are on blood pressure medications, and they can vary. They can vary. Not every person on high blood pressure medication is having erectile dysfunction. So very important to warn patients against if they are having erectile dysfunction or if they are worried about erectile dysfunction, that this medication, yes, they can do. However, this doesn't mean that if you are actually taking this medication that you're going to have an erectile dysfunction. First of all, to start with, even though if you start medication and start getting symptoms, at that point, what we can do is either to switch your medication into a different one, or we can still even add medications that can help with erectile dysfunction. Things like what? What medication helps with erectile dysfunction?
Viagra? Over the counter?
Sildenafil. Yes, sildenafil we do prescribe. Viagra is over the counter. Okay, and imagine another scenario: patient coming to you, and this patient actually is a psychosis patient. Patient is on olanzapine, for example, for their psychosis, and this patient actually coming to you have had their blood pressure being checked recently, and the blood pressure was on the higher side. Now, the patient worried about olanzapine. So olanzapine, does it cause high blood pressure?
No.
Okay. Any other thoughts?
Olanzapine is slightly sedative, but I don't think it causes high blood pressure.
Right. Okay. Yeah. Perfect. So, I mean, it's not because of sedating, but olanzapine actually can cause postural hypotension. Olanzapine can cause postural hypotension. Okay. So it doesn't normally cause high blood pressure. But what is the risk? What is the risk of heart disease in this patient? What patient with psychosis? Actually, patients with psychosis have a higher risk of developing cardiovascular disease anyway. Okay. So It's not because of the medication, it's mainly because of the current condition, and of course, lifestyle, things as well, like smoking, alcohol, also in addition to weight, and also diet. Very, very important to go through that as well. So this medication doesn't cause that. Okay. So these are very important things to bear in your mind. In addition to that, if a patient coming to you and the patient is actually homeless patient coming to you telling you, doctor, my blood pressure, I checked it once before in the pharmacy and was on the higher side. However, I do really struggle to get an appointment with a GP. How can you help the homeless patient? Homeless patient can really struggle to get, in a fixed place. They don't have a fixed address, for example, and sometimes they tend to travel from a place to another. So how can you help a homeless patient with high blood pressure?
Can offer him to,
if
he can, sorry, yeah, please carry on.
I was thinking to do a pharmacy. You can go to Boots and then check his blood pressure at the pharmacy, and then the pharmacy can send us the record.
Absolutely. Okay, so this is an option. The second option can be if you set regular appointments for the patient with reception, so that we make sure the patient gets regular appointments on time and they don't miss any appointment. Because many homeless patients, actually, they don't have a mobile phone even. They don't even know how to read and write. So we need to set appointments. We need to set reminders. If the patient actually, they don't have a mobile phone, for example, what can you do? We can ask them whether or not they have a friend who has a mobile phone, when we can give them a call, when we can actually text them and they can get in contact with themselves. Okay. If a patient is a homeless patient and they don't have a fixed address and they need to go to be seen in hospital for any reason, and they're going to receive a letter by post, how can we make sure that they attend their hospital appointments?
We can receive their letters and we will inform them that in the surgery we can.
So we can register the surgery's address as a patient's address. This is absolutely fine. This is absolutely fine. And we can find a way contacting the patient, or even setting, a pre-bookable appointment for the patient, so that we make sure they come maybe in 2 weeks' time just to check on their records and see whether or not they have an appointment with this specialist. Okay. So everything. Remember, we mentioned before the professions of a GP. So the first profession is, of course, you are a GP. The second profession is that you are a problem solver. Okay. So you need to be a good problem solver. So know where the problem is and act on it. Very important. This is how you can address patient concerns as well. Another thing is actually you need to be a very good salesperson. Know what to sell to the patient, what kind of medication, why you're prescribing this medication. Always explain why you're doing this step, why you're bringing the patient for examination to do what, why you are prescribing this medication to do what, why you are referring the patient because the specialist is going to do this and that. You need to be a very good salesperson. Sell the information to the patient in a good way so that they can make an informed decision whether or not they agree with that. Okay, perfect. Hypertension in pregnancy also is very important. You need to divide it into either pre-existing hypertension or pregnancy-induced hypertension. What is pre-existing hypertension? Pre-existing hypertension is a patient, and due to the initial visit with the midwife, booking visit, the patient has already had hypertension. Patient is already hypertensive anyway. However, what is pregnancy-induced hypertension, and how can we differentiate between it and the pre-existing hypertension? What is the cut-off number of weeks in pregnancy-induced hypertension?
20 weeks.
20 weeks, perfect. So if a patient has already had hypertension, so this is pre-existing hypertension. However, if the patient started to get high blood pressure 20 weeks onwards in pregnancy, this is pregnancy-induced hypertension. Perfect. Is there a difference in treatment between them both? Yes, there is one difference only. What is this difference? So the difference is that if the patient has already had pre-existing hypertension, you should be treating the patient as a normal patient in clinic, meaning that the patient, actually, you can take the lead and start treatment. However, you need to inform the midwife, you need to inform secondary care about this patient because they need to arrange follow-ups as well. Okay, so if the patient is an hypertensive patient anyway, we normally treat hypertension in primary care, which is perfect. So if the patient is a pre-existing hypertensive patient, what can we start the patient on? Now, if a patient is already on things like indapamide, things like ramipril, can the patient continue taking these medications?
No.
No. Oh, perfect. So what is the first line? What is the first choice in such case? Labetalol, of course. Thank you. So if the patient is asthmatic or if the patient is having, contraindications to start labetalol, so it's always nifedipine or methyl dopa. Okay, but then, I mean, the first thing actually we tend to start the patients on is labetalol. But again, if contraindications, then the next step is going to be nifedipine, then it's methyl dopa. Okay, we need to stop any other medications the patient on, I mean, mainly ACE inhibitors and diuretics, and the patient needs to be started on aspirin 75 to 150 milligrams daily from 12 weeks onwards. Okay, now what is the difference between that and pregnancy-induced hypertension? The difference is that you don't touch anything. You don't touch the medications the patient on. It's just you need to update the antenatal team. You need to speak to the antenatal team actually as soon as possible, actually during the same day. Let them know about that, and they take the lead at that point, and they start the patient on labetalol and aspirin, because very important, hypertension and pregnancy, specifically if the patient hasn't been hypertensive before, there is a major risk, a huge risk. And what is this risk?
Is it a preeclampsia?
Preeclampsia, yes, perfect. Okay, so if a patient has already been hypertensive, okay, so I mean, we already know that the patient is hypertensive. Yes, there is a risk. However, if a patient hasn't been hypertensive in the past, there is a major risk that she can rapidly develop preeclampsia. That's why we need to update the antenatal team straight away if the patient started getting hypertension more than 20 weeks of pregnancy. What's going to happen? So blood pressure needs to be checked, and urine ACR should be done in every and each antenatal visit. Okay, ACR, very important. Why? ACR can actually as well can guide our treatment plans. So if ACR is, let's say, if the patient actually is having +1 protein, what should you be doing in their urine? Is their urine, and they are hypertensive patients. So +1 protein, what do you normally do?
Just keep on monitoring.
No, you do ACR?
You do ACR and?
Refer? Oh.
No. 1 plus protein, we do ACR and we do urine culture as well. Urine culture, okay? However, 2+ proteins, what do we do?
With hypertension, hospital.
Same day, urgent same day assessment, because that can rapidly develop into preeclampsia. Okay, can rapidly develop into preeclampsia. And what is also another cut off to refer patients into secondary care if they have high blood, their blood pressure is actually equals to or above 160 over 100. Any patient who is pregnant with their blood pressure 160 or 100, hospital, major risk, preeclampsia. Okay, if a patient actually is pregnant, always encourage patients who are pregnant, actually they need to see midwife, specifically early on in pregnancy. In addition, they also need to be on folic acid and vitamin D, at least folic acid, at least the first 3 months time of pregnancy. Very important to take folic acid. Yes, Dr. Pedro.
Sorry, if a patient got blood pressure of between 140 to 160 and urine deep showed only 1 protein, I normally speak to the obstetrics team. I don't bother to manage it. I just pass it across to them.
Okay, but let's stick to our guidelines then. Okay, let's stick to our guidelines. I know what you mean. That's why we. Okay, so that's like many GPs do that in day-to-day life. However, we stick to our guidelines. If patients are actually, their blood pressure is between 140/90 to maybe 159/89, that still can be manageable, specifically if the patient has been hypertensive in the past. However, +1 protein on its own doesn't guarantee or doesn't warrant patient to be seen in the hospital. However, 2+, the patient needs to go straight away to hospital. Yes, Dr. Yasser.
So I just about the pre-existing hypertension you mentioned.
Mhm.
Can we start the medications when we detect this high blood pressure? Like, can we start labetalol for the patient and aspirin, or should
Pre-existing hypertension, do you mean, Dr. Yasser? And pre-existing hypertension, right?
Yeah, pre-existing hypertension.
Yes, of course you can start. You need actually to start the patient if it's pre-existing.
So it's primary care, yeah? We don't need
primary care. This is what we've mentioned, yes.
Thank you.
And just to save everyone's time, can we actually leave questions till the end, please? Because today is going to be a very heavy day, So leave questions maybe in the break.